Thank you, and hello everyone, and thanks for giving up your time. I wonder if there's a subliminal message in the palliative care session being the last session of the series. I hadn't realised that. Firstly, I just wanted to say some of the things that we will talk about today might trigger in you some emotion. We all have lived very different lives and experienced very different things. And sometimes emotions can hit us out of the blue and we're not quite expecting it. So if that happens to you, that's okay. Just give me a little wave. There's some tea and coffee and some couches, and you can take a bit of a time out and come back if and when you want to. And if you don't want to, I won't be offended, but I'd like to know that you're okay. So just give me a happy wave on the way out or something. If you're not okay, I'll give you my details and we can talk privately. Okay. So thanks for giving up your time to come along to this. This is the first of these sessions I've done, so I am a little bit nervous, but we'll see how we go. So today we thought we'd talk about how can we start talking about dying in our community? How do we take away the taboo of death and dying? What is palliative care and how can I access it if I want to? Are palliative care and end-of-life care the same thing? And we're fortunate to be able to hear from a patient's perspective that it's not all about death. Right. Having said that, the patient who I will show a clip from has since passed away. So if that is too difficult for anyone, I'll give you a warning that one's coming up. Okay. I think in some cultures it's actually, it might offend people. So first I'll give you a little bit of an ad about who we are and where you can find us. So, as Serena said, I've worked for Barwon Health now for over 10 years. And actually, even working in oncology, it took me quite a few years to realise that there was a palliative care team out there. So even within our own organisation, people still don't know that we exist. We're hidden away over at the McKellar Centre, which, separates us, I guess, from the acute sector, but we've got a lovely little site over there and we've developed this program based over there. So we're made up of a community palliative care team, a hospital-based acute consult team in the hospital, and the palliative care unit. So they're the three main arms of the team. We also provide consultation and support to the Barwon Southwest region. So actually our remit goes all around that Barwon Southwest region, out to Warrnambool, Hamilton, Colac and down to the Bellarine. So we spread our arms quite wide. So community palliative care provides specialist care in a client's home or in an outpatient clinic, as is appropriate to them. For some people, it's too difficult to get into a clinic and we are more than happy to visit at home. We provide assessment for symptom management, with our goal being to help people to live better for longer, to reduce pain, breathlessness, constipation, nausea, stress, anxiety, all of those things. And we provide advice and support on a needs-based model of care, meaning that for some people, they'll actually require a lot of resources and a lot of support and a lot of visits. For some people, they won't. But just knowing we're there and that they can call us 24 hours a day, 7 days a week is the support they need. In those people, we might only see them every 8 weeks at home, but in someone who acutely needs us, we may be visiting daily or twice daily. To give an idea of the size of the region that we cover just with the Barwon Health Community Palliative Care team, we've got, I think, 9 nurses, all of us part-time, so making up not quite a full contingent. We currently have over 200 patients in the community program. They range geographically from Little River to Lorne, out to Inverleigh, Meredith, Teesdale, up that direction. And then we border on Bawtry Road in Leopold. So that's where we then cross over with the Bellarine Community Health team. And from Winchelsea, we then hand over to the Colac Community Health team. But it's a really large catchment. That's a really large area for a relatively small number of nurses to be covering. So as well as nurses, we've got a consultant palliative care doctor on our team, a registrar. We've got a nurse practitioner, clinical nurse consultants, specialist palliative care nurses, and we also run clinical trials, which is a good, interesting part of the work we do. We've just recently taken on now a community pharmacist. We've got a dynamic volunteer coordinator, and I'm proud to say we have about 85 volunteers who are doing the most amazing work, and we'll touch on that later because they really do form the heart of who we are and what we can offer to people. We've got a psychologist, social worker, grief and bereavement counsellor, and a spiritual care worker. So that's the community team. And then we have the acute consult team. So those of you who work in the hospital may have come across them. We don't have admitting rights to the hospital in palliative care, which is a bit disappointing. And that's another story for government funding. But what we do have are some really a skilled team who can come around and offer consulting advice on the ward and then help in discharge planning. So whether that patient is then discharged home with the community support or perhaps a step-down discharge or an end-of-life discharge to the palliative care unit. They can also be called upon for acute symptom management of those symptoms we talked about, pain, breathlessness, all of those things. So they're made up of, again, another consultant palliative care doctor, registrar, nurse practitioner, clinical nurse consultant and specialist palliative care nurse. And then we have the palliative care unit. So that's a 16-bed subacute unit over at the McCalla Centre. They're all private rooms. They all have their own bathrooms. There's a real effort made for the palliative care unit to seem not like a hospital, but well-staffed with specialist and experienced staff. We encourage people to make their rooms their own if they're in for a longer type stay. And if pets form part of your family, then they are welcome too. So in the unit, again, we've got another palliative care consultant doctor, registrar resident, the nurse unit manager, specialist palliative care nurses, physiotherapist, occupational therapist, social worker, grief and bereavement, and spiritual care. And there's one of our beautiful volunteers, Norm. Norm's in charge of happy hour. Although it looks like she's having water, she might have missed out on the brandy that comes around on the drinks cart. As I mentioned before, we have an amazing team of palliative care volunteers, and they provide practical help, companionship, comfort and compassion, and they do that via a number of programs. We'll come back to the volunteers because I want to show you some of the great work that they've been doing and how they are actually enabling us to sort of move towards that compassionate communities model that we're hoping to actually lead in rather than follow. So to be referred to the palliative care program, you can be referred to the community program, the acute consult program, or even a clinic. So the cachexia clinic is probably one of the more popular outpatient clinics. That's a really well-resourced one. That referral to palliative care can come from your GP, your specialist, or yourself, or your family. So we will always accept a referral from someone who feels that they need us. It may be that we only meet with you once, we work out what the needs are, and we can refer on, but we are more than happy to take any inquiries from anyone who thinks that there's someone in need of specialist palliative care. And our details are on there. So people requiring community palliative care are generally referred by their GPs. That would be, GPs and oncologists would be where most of our referrals to the community come from. But as I said, we're happy to answer questions from anyone about referrals to palliative care. So what is palliative care? So a bit like all of us nurses sort of bow down to Florence, us palliative care nurses bow down to Dame Cicely. So Dame Cicely Saunders trained as a nurse initially, and then she became a social worker. And finally, because she wasn't getting what she wanted and they all said that a doctor needed to tell them so, she became a doctor. So that was her way of saying, I told you so, and she probably told them so when she was a nurse. So since 1948, she's been involved with the care of patients who have a terminal illness. And in 1967, she established St Christopher's. So that has been the start of palliative care. So we could say it's relatively new as a specialty. as far as it being specialist palliative care, so when I've touted off about all our specialist doctors and nurses, but palliative care itself, of course, has been going on for hundreds and hundreds of years because it's the care of someone with a terminal illness. So there she is. It's not a great picture of it, but... So palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial and spiritual. And like all WHO descriptors, it's really wordy and long, and so we break it down a little bit. So some people think that this is what we do in palliative care. A lot of hand-holding, a lot of looking into people's eyes. That's a really important part, but it's not what we do. Some people think this is what we do in palliative care. That's also not really what we do. And for some people, when we're referred to palliative care, this is what happens. If you can't read it at the bottom, that says, don't freak out, it's just a save the date. Unless we can start talking about palliative care, talking about terminal illness, talking about death and dying in our community, when people like us go to someone's door, it gets shut. I've actually physically had a carer stand at the door and hold me by the arms saying, I don't want you to come in, I don't want you to come in. And I said, what do you think I'm going to do? They said, you're going to take him away. And I said, no, I'm here to help him stay. He stayed for another 6 months at home, had lovely things happen in that time, lovely visits from grandchildren and all of those things. And when he died peacefully at home, she held me by the arms again and said, I don't want you to go, I don't want you to go. So, it's all a matter of people's perception of what palliative care can do. There was a gentleman, I love the humour of farmers, the men of the land. And I used to knock on his door out in Country Vic, and he'd say, oh, here she comes again, the bloody angel of death. But he let me in every time. So palliative care is care that helps people live their life as fully and as comfortably as possible when they have a life-limiting or a terminal illness. But that's the focus. The focus is on quality of life. And it's been proven that people who have impeccable palliative care actually live longer. It's focused on providing relief from symptoms, relief from suffering, relief from the stress of having a serious illness. And the goal is to improve quality for both the patient and the family. Palliative care is very holistic. As I said before, if the dog is part of the family, then it becomes part of the people we care for, animal we care for, unit we care for. It's person and family-centred care provided for a person with an active, progressive, advanced disease who has little or no prospect of cure and who is expected to die, and for whom the primary goal is to optimise quality of life. So far we really haven't talked about end of life, have we? So, palliative care, the focus is really on the quality, it's on the living. It identifies and treats symptoms which may be physical, they may be emotional, they may be spiritual, or they may be social. Because palliative care is based on individual needs, the services will differ, but they can include relief of pain and other symptoms, nausea, vomiting, shortness of breath, distress. Distress is something that I guess we don't think of as a medical ailment, but certainly it's something that if we can alleviate distress, we actually find that is a really good pain relief, because pain takes on all sorts of manifestations. We can also provide resources such as equipment and aids to help people stay at home. And in fact, although we have very little funding, we do have a tiny little slush fund for the types of equipment that will stop someone going back to hospital, and that's all that we need to prove. So if we put a hospital bed in here and we fund it and that person can stay at home, that absolutely is something we can find some money for, because the importance is around staying at home. Recently it came to light that we'd overlooked something when we were providing funding, and that is that if a patient went into the hospital or into the palliative care unit and had their end-of-life care there, all of their medications were paid for. But if they were at home, they were having to go to the community pharmacy and pay exorbitant amounts of money for medications to keep them comfortable at home. So we were really lucky to partner with the Geelong Hospice Foundation, who have been fabulous. We go to them with projects and they do what they can, and they are now providing the funding for all of our patients who wish to have their end-of-life care at home. So that makes a really big difference for people. I mean, it just seemed completely unfair that, that you had this expense because you'd chosen to stay at home with your family. So we also provide assistance for families to come together to talk about sensitive issues. We all live in different families, we all have different relationships with people. And for some families, being open and honest and frank and talking about all of those things is normal for them. And for some, it is absolutely not normal. And there is stony silence and no one will say the word. Or they might be broken families and you're trying to bring them back for a semblance of being with someone who would like to see them all together for a last time or something. So we're really lucky we've got a fabulous supportive care team who can help bring those sorts of things together into open discussions and talk about things. And also then around, the social work interventions around any financial supports and home help and all of those things that help people to stay at home. If you've got someone needing round-the-clock care at home and the person who's providing that usually goes to work, obviously that's going to have a massive strain on families. So we try as much as we can to help facilitate that to happen. So the principles of palliative care is that it affirms life and regards dying as a normal process. It doesn't hasten death or postpone death. It provides relief from pain and other distressing symptoms. It integrates the psychological and spiritual aspects of care, and it offers a support system to help patients live as actively as possible until death. And you'll see how actively people can live until death as when I show you the fabulous things our volunteers have been doing. And I may or may not be trying to recruit people to volunteer programs. So there is a difference between palliative care and end-of-life care. They do meld together because if we're treating someone and looking after someone who has a life-limiting illness, then at some point we know they're going to die and that their end-of-life care will become part of what we do. I think the misconception, and I think the thing, if there's one take-home today, is that palliative care is not just end-of-life care. So if someone's referred to palliative care, it doesn't mean that they are imminently dying. We have someone on our program who's been on the program for 4 years. I don't think he's any closer to dying today than he was then. He might surprise us, but in that time, we've managed to support him through all of those things that have come up for him, physical symptoms, support with linking families, all of those things, and he's found that super valuable. So if we ever talk to him about being discharged, which we do from time to time, discharge people who are travelling along well and not really needing us, he doesn't want to let us go either. So, and that's fine, we like him, we'll keep him. We don't know exactly when end-of-life care is going to be needed for some people, and in some people we can project it. There's a whole bunch of graphs that show what cancer does as opposed to what end-stage respiratory failure does, as opposed to what dementia does. So some are predictable and some are not. Previously, I've been the MND specialist nurse, so motor neurone disease specialist nurse for the region. And although we can talk about trajectories and timelines with motor neurone disease usually pretty accurately, the number of people who die from something else while they have motor neurone disease actually still surprises me. So we don't know when end of life is going to be. But if we know that someone has a life-limiting illness, we're involved in their care. The transition to then providing end-of-life care in their place of choice becomes a natural progression. So there's no clear-cut definition of end of life, but it refers to the last few days of life when a person is irreversibly dying. So no matter what we would do, intervention we could give at that point, our focus then becomes purely on comfort. So caring for patients around the time of death has always been at the core, but it's not the only thing we do. So good end-of-life care is based on the understanding that death is inevitable and a natural part of life. In fact, our spiritual care worker is very fond of saying, 1 in 1 of us will die. It's 100% guaranteed. It's about the only guarantee we get. They say death and taxes are the only guarantees. As the final stage in a person's life, it is a uniquely important time for the dying person and their family and their close friends. And that's something we recognise. We talk a lot about people's place of choice. So the decision of where they would like to have their end-of-life care. Publications like Palliative Care Australia and stuff, to me, put this emphasis on people saying that they want to die at home. They say that 70% of people want to die at home, but only 20 or something % actually do. My experience over the last nearly 7 years in palliative care in the Barwon region is that it hasn't always been that high. So for lots of reasons, people don't want to die at home, and that's okay. That is fine. I think that there's a big focus on it being choice, but then some people can feel compelled to say, oh, well, I should die at home because that's what's expected now. For some people, that's absolutely not what they want to do. But what we need to make sure is that the venue that they choose understands and is able to provide appropriate end-of-life care. We don't like to think that our patients are in a 4-bed ward with total strangers. It's not the ideal for us. But for someone else, it might be their ideal, and, we'll support that in any way we can. So at end of life, our goals are to maintain someone's comfort, to provide choices for individuality, to enhance quality for the dying person, and to support their family. We want to reduce burdensome interventions and offer choice of place. So we need to have been having those conversations about what burdensome interventions might be. And again, some people will say, I want it all. Take me to ICU, do all of those things. And we talk to them about what that might look like for them and their family, and they're often hard discussions, versus providing comfort when there is no alternative. If we thought that we could turn around whatever the problem was, of course, we would support that 100%. But if someone is inevitably dying, then our focus will be on reducing those burdensome interventions. The big one. Have you thought about your end-of-life care wishes? So, we're really lucky at Barwon Health that we have a fantastic team who can assist with advanced care directives. So there was a shift in March about what they look like, and they're now a values directive and a treatment directive, essentially. So there's the one that says, this is who I am, this is what's important to me, this is what I want people to know about me if I'm not able to tell them. And then there's the treatment order or refusal of treatment order that actually is then the binding part that as health professionals we have to abide by. So that's the sort of document that can come together, and respecting patient choices are very helpful in those things. And some of you may have actually received already those GPs. Officers put that out, I think at the age, I don't know, I think it's 70 or something that they come out, and it becomes a regular thing, a discussion to have. But even if you don't go as far as to document all of this and write it down, it's important to start thinking about yourself what's important to you and what would you want, and to tell people about it. Tell the people you love. We don't always know that death is around the corner. We know that accidents happen and cerebral accidents and cardiac accidents and all of those things can happen. So what you don't want to do is leave the people that you love wondering what you would want. So having the conversations is really important. Listening to the conversations is really important too. So if someone wants to tell you, it means they care about what's going to happen. So listening to them is really important. But how do we start talking about dying in communities? As a palliative care nurse, I could go to a party, meet someone for the first time, and they say, "Hi, I'm so-and-so, what do you do?" And I say, "Oh, I'm Mel, I'm a nurse." And they say, "Great, what sort of nursing do you do?" And I say, "Palliative care." And they say, "I'll just go get another drink." Right? It's not the one that people, I don't say I'm a midwife because people get all excited about birth, but they don't get very excited about death. In fact, they don't really want to talk about it. But we've got to change this because, as we know, 1 in 1 of us will die. And we want to do it well. We want to do it well for the memories of the people that we leave behind. We want to do it well for ourselves because we deserve it. But we need to start talking about it. So there is a program that Palliative Care Australia, an initiative of theirs called Dying to Talk, and some of you may have seen what we did for Dying to Talk this year, which is on August the 8th. It's always on the 8th of the 8th. And the idea of it is that we want to encourage Australians to start talking about dying. And we did I'll show you later, but we did the Before I Die wall in Little Mallet Street. Where all the groovy bars and things are? Little Mallet Street? Yeah. So we did that there. And it was on this little sort of side wall near a car park, and I thought, we've just been pushed into the corner again. No one wants to know about, Dying to Know Day. And 24 hours later I went back and it was full. People had just written all their wishes all over it, and we only had one little bit of graffiti to rub off in a whole week. So I thought that was pretty encouraging. So look out for it next year. It's going to be bigger and bolder and better because we know the Geelong community is so embracing and things like this. So the idea of that is that we get communities and groups to start talking about dying, because according to the statistics, 82% of Australians think it's important to talk to their family about how they want to be cared for at their end of their lives. And I just realised I don't have my notes coming up at the bottom there. I can't remember the statistic, but it's around 20% of people actually do talk about it, and even fewer document it. So this is where we've got to start changing the community sort of perception of talking about it. And for those people who did talk about it in this survey, the most important things were about being pain-free, which I think is really, really reasonable, but I have to say is sometimes not 100% achievable. There are some pains that we can't take away because they're not always physical. So 100% pain-free is probably a very difficult thing to achieve in most people, but we get very close. Being in the place that you choose, whether that's at home or in the hospital or in a hospice or in someone else's home, if that's a better home to be in. Being able to enjoy your last days, and I think that's pretty reasonable, and that is also achievable with really good care. And having those close to you supporting you. So the way to get that is to start talking to them about what that support would look like. So what we want to do is break the taboo, start talking about death and dying and bereavement, because it is a part of life. So many cultures celebrate death around the world in a very different way to the way we do. And maybe we could use that to start thinking about how we start to reshape our thinking about death and dying. Now, I'm not very tech savvy, and I've just realised that I need to actually see what my notes are for these clips, because that's not... How do I do the other screen thing? Is it that one? That's a bit embarrassing. Yeah, but you know how you can get them on the screen so that they don't have to see my notes? Ooh, no, go back. Okay, anyway, so I'll just go from memory. But in New Orleans, they have the jazz parade that forms part of that forms the funeral procession. So it becomes a real celebration. And so the jazz performers and the friends and family will start their procession at either the church or the funeral home or the family's home. And they start off using fairly low sort of sombre type music, and they parade all the way along to the cemetery. And once they lower the body into the ground, they call it the casting off. They fire up the music and get really loud, and they all dance their way back along the street. So a real celebration. And I mean, I'd love to see a New Orleans jazz band. That would be on my bucket list. In Bali, a place where I spend a lot of time, in the Hindu culture, they treat the body as though it's still alive. So they'll look after the body and talk around the body and be their normal selves. And then when the time comes, they will then be cremated. And they believe that by cremating the body, that the spirit can then be reincarnated. In Ghana, they have what they call fantasy coffins. So they create these coffins where what was important to the person in life becomes the fantasy coffin, and they get to go into the next world in this fantasy coffin. So it may have been, you know, for someone, I'm not quite sure what a crab means in someone's life, but yeah, that's a big crab. You know, but you know, they're flying off in the aeroplane and things like that. So again, colour and movement and hope, I think, is the other thing. And very timely, tomorrow is the day of the start of the Day of the Dead. Today, happy Halloween, everybody, if that's something that you follow. But in Mexico, and based on Spanish tradition, and I don't know the Spanish term, but tomorrow being the 1st of November will be the Day of the Innocents. So there's lots of music and celebration, and people would visit cemeteries to respect and honour those who have died young. And then on November the 2nd, it's the Day of the Dead. And it's a real festival around remembering people and honouring death and all of those things. And again, lots of colour and sound and movement. This one in Indonesia is actually, that's my great-grandmother. So I lived in Indonesia, and she was 96 when she died in 1986. And I'd never actually experienced death before. So my parents did what lots of parents did, left me at home. So they went off to, we were living in Jakarta, she was from Surabaya, they went off to Surabaya. Actually, only my mum went. She went off to Surabaya, we got, Nana's died, Omar's died, and that was the end of that. What I found out years later, talking to my mum about this, was that she was absolutely shocked, because even though she was a grown woman, she hadn't faced death in that way either. We hadn't talked about it. But here she was with her family laying out Omar in the home. And she found that so confronting, because in Australia, we outsource death. We don't lay out our loved ones and provide that care generally. Someone else comes and does it. So Omar was laid out by her family on the dining room table in the middle of the home, and the grandchildren, not us, the other grandchildren, and lots of people visited, and kids played around them, and she stayed there for days. And that's just how they did it. And then she was buried when everyone had said their goodbyes. But that was probably my first inclination that death was something you didn't talk about. You stay here, I'll go off to Surabaya and deal with it. We tend to treat it a lot more like this. And I'll say that this is actually the funeral hearse of my colleague Jill. This is her dad's funeral, and she was very pleased to share it. But her recollection of this is in England, it's even a little bit more uptight than we are in Australia. So he went off to the local cemetery, and they actually have to, by law of the village, have a committal. So there has to be a minister who has to say those words, ashes to ashes, dust to dust. You know, there's not a lot of flexibility, and again, a lot of outsourcing. You know, he was whisked away, and that was it. Interesting how different places treat death and dying, and this one is New Zealand, and this would be one of my favourites. Woo! Let it go. Oh, here we go. Have we got sound? Oh, it'll get louder in a minute. So this is a school in New Zealand where a teacher had died. Oh, we're going to be buffering. So that's, the teacher had died, and they drove the hearse through the school, and that was how the students greeted or farewelled their teacher. It is, isn't it? I don't traditions in different places. So in those cultures, the sense of community is really, really strong. And it's something that I think we're good at in lots of ways. You know, if you back for the cats, you've got a really strong sense of cats community. I'm an unfortunate Carlton supporter. But community can be found in lots of different ways. I guess what I'm hopeful for, and the way my role's changing, is that I'd really like to be able to engage our Barwon community to not only become a compassionate community, you're fine, but to lead the way in this. And there's some small towns in sort of New South Wales hinterland there that are really doing some great work, and I think that we could do the same thing. So, you know, it's just about coming together as a community and supporting the people that need it, and those people are our dying. So that's the Before I Die wall. That's one of our gorgeous volunteers. And that whole sort of blackboard was just full of people saying that before they die, these are the things that they wanted to achieve. And I did this with a bunch of students, and the things they came out with were just so mature, and, you know, you'd think that I thought we'd get graffiti all over that, really. But people take this seriously, and it's really encouraging. So I think it's only going to take a small prompt, and we'll all gather together for this. We've also engaged our community, speaking of football, with the volunteers have started a program called Backyard Blitz. I'm sure that that's probably copyrighted by Jamie Drury or something, but anyway, no one's sued us yet. Yeah. And, you know, this gorgeous couple have been on the Palliative Care program for quite a while in the community, and the East Geelong Football Club came together and helped them turn over their garden beds ready for the next season of vegetables, because that's what they'd done all their lives, and they just weren't able to do that any longer. So that's an example of the community getting involved. So compassionate communities is a term that you might start to hear, but it's a whole of community approach to end-of-life care, where caring for one another at times of need, loss or crisis becomes the task and responsibility of everyone. Not just calling the nurse or the doctor, you call on the community, because some things are medical, but most of them are not. Most of them can be addressed by your community, and probably better than outsourcing to someone else. And the other message is that it's not all about death. And I guess the people that don't want to talk to me at parties because I'm a palliative care nurse probably think that that's what I'm going to talk to them about. And I might if I've had a lot to drink, but I might not. But, you know, yes, death is part of what we do, but this is the stuff that we do. So, you know, these are some of our volunteers interacting with our patients in programs like the Life Stories program and the Dignity Therapy program. We do home visits, massage at home, hand massage, foot massage, you know, all of those sorts of things that just help people feel good and feel less socially isolated. And there's those things that people want to do that they haven't had a chance to do, and we try and make them happen. And that's where I say we've got the most amazing volunteer coordinator. This lady wanted to stroke the belly of a crocodile. That's in the palliative care unit, a crocodile. And she stroked the belly of the crocodile. And for her, that was just something she so wanted to do. The lady in the red here has motor neurone disease. And she wanted to ride a Harley. Well, her holding on to the man in the Harley would not have been a very good idea. Her strength wasn't quite right for that, but riding along in the sidecar there was just exhilarating for her. She loved it, loved it. It wasn't enough, however. She then wanted to go up in a helicopter. And can I say, there is not enough money in the Barwon Health Palliative Care coffers to do this. We were fortunate that MND Victoria came to the party on that one. So if we can't do it, we'll find someone who will, and they may be the people in our community. There is a lady on the program who wanted to learn glass blowing. So she has just made beautiful glass Christmas ornaments for her children. So a lasting legacy, and something she just, you know, she wanted to try. So again, put the feelers out and found an artist who could do that with her. So, and I'm pretty sure they probably didn't talk too much about death while they were doing that. One of my favourites, probably because I got to eat some of the results of it, is another young lady who wanted to learn to make cheese. And amongst our volunteers, we just happened to have someone who knew how to make cheese. So they went and made cheese, and then they sent it back into the office for us to eat, and it was delicious. But, you know, again, it was just, I guess the interesting thing here is that she was a young woman who felt she didn't need supportive care. No, I don't need to talk to anyone. No, my children will be fine. No, we don't need social work. We don't need a psychologist. And that's quite common. People don't want to let other people in. They'll let nursing and medical in. but getting a supportive care team in can sometimes be a little bit challenging. The perfect way to do this was the social worker went and made cheese, and they started to chat over cheese making, and that made all the difference, because all of a sudden it opened up that bit of care that we couldn't provide, we could provide over cheese making. One of the programs that we are especially proud of, and that has won awards, which I had listed in the text bit that I can't get to, but it was the Premier's Awards anyway, in 2017, was the Dignity Therapy Program. So this is a piece of legacy work. It's led by Russell Armstrong, some of you may know him through Barwon Health, who's our spiritual care worker. And he went and worked directly with Harvey Chochinoff, who developed Dignity Therapy, and became a facilitator in that. So he came back to Geelong and started Dignity Therapy here. He's now rolled it out to the volunteer program so that they can carry on the work, because it got bigger than what he could do himself. And he's now facilitating this in pockets throughout Australia. So we're actually, Geelong's leading the way on Dignity Therapy. And we're really proud of it. And we're especially proud of it when we get to show you what it means to people.
I said to my wife, if there are things that I can do to keep myself alive longer, I think I'd like to do that. That's the inspiration that I had gotten from this therapy. Motor neuron disease is what I have, and they call the type I have got flail arm. So I can't move either arm, and it's possibly just started in my left feet. Yeah, but it's a disease that wastes the muscle away. In 2015, one of my trainers had said to me, my left arm was appearing to be a little bit thinner, and that I was starting to have a bit of a hole in my left hand shoulder blade. And on those comments, I went to the local doctors, who sent me then to the neurologist. And then on one consultation, he was able to ascertain what I had. I think I may have had again selected hearing, and he had said to me, buddy, if I was you, I'd be working on my bucket list. Yeah. I was just left stunned.
When he was in the early stages, it was quite good. He was quite mobile and still very active. So we joined the RACV club, and we're still going to the gym, and took up aqua and made a lot of friendships. And we also took up travelling. So we did quite a few trips. The biggest one being probably my birthday in 2016, and we went back to his father's born, an island in Italy, and renewed our vows, which was a big highlight for us both. And our very last one was probably last year, and we took off to the Maldives, and that was super special. But soon after that, he started to deteriorate a little bit more, and travelling was becoming all too difficult. And then he hit a rock bottom, which was earlier this year, and lost his will.
I was convinced when I woke up that morning that I wanted to die. And I said to my wife, babe, don't talk to me today. I got nothing good to say.
I called Russell to come out in the hope that, we could give him some faith and will to continue living instead of being with us. And that actually happened.
The next day I had met Keith, who coordinated my dignity therapy.
Bruno was in a fairly low spot when I first met him. He was clearly physically struggling with his illness, but also he hadn't said before what he needed to say. I explained dignity therapy as an opportunity for people to create a legacy document which incorporates the important things in their lives. It incorporates the things they're proud of, the things they've achieved, but also incorporates their values, the things they've learnt about life along the way, and messages they like to give to their loved ones. It's not a full life history, it's much more than that. It's more about who they are as a person and what they'd like to be remembered for, and the things they want to say to the people who are the most important to them.
It had been uplifting for me. It revealed a lot about myself, and to have that read by my wife for the first time to my parents. My dad kissed it and he held it close to his heart. And that was a joyful thing. It's just amazing what that book of reflections is able to bring me. It had created the space for me to tell the important people in my life who they've been for me. And that was just an unbelievable, uplifting feeling to have drawn the courage from this document to have done that. It was amazing, not only for me, but for those people. I get all my family and friends that come to visit to read that booklet back to me. And it keeps creating magic in new conversations for me. I had discovered this will to live longer.
I think it's a must. I think anyone that's going through an illness or a terminal illness, it definitely brings, hope and faith to a person and gives them a purpose. Gives them a purpose to keep going, keep fighting. It's made the world of difference to us in particular, and my children and the whole family. Yeah, it's definitely been a magical thing, as Bruno says.
Time is of the essence, and I think that's where my true values have shifted towards, understanding that time is the biggest gift that anybody can give of themselves.
Now, Bruno would have loved for me to let him have the last say, but I'm not going to. I'm going to give it to Dame Cicely Saunders, which would really annoy him. But I was his nurse, so I'll get away with it. You matter because of who you are. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but to live until you die. So thank you again for coming and spending your time listening to me. I really do appreciate it. It's probably not a topic that you'd go home and say, wow, about, but you know what? I hope you take home some things. It might be some more questions, and if that's the case, email me or ring me. I'm on that number as well. If you want to know more about palliative care, if you've got a question about whether someone should be referred to palliative care, just ring us. That's what we're there for. If you want to join our team, we'd love to have you. We're constantly expanding, and it's certainly an area that is the most rewarding work I've ever done in my life. And I've done a few jobs before nursing and a few jobs in nursing, and I will not leave this one. This will be my job forever. So, has anyone got any questions there? Yeah, so the question was, how does our team care for each other and for ourselves? We have a fabulous supportive care team who actually then turn their skills inward to our own team. Like everyone else, we can also access staff care. But we have monthly debriefing, and that rotates through our supportive care team because people need different things from different people. So we do that every month, which can take the form of lots of different things. We've been out in the yard there doing yoga, and we've done meditation, and we've done signposting cards and lots of different things. We are certainly, we're a very close team. I think that when you do this work together, you do become very close. So some of our support, as one of the senior nurses, I am one of the support people that people come to, and often it'll be that we just need to go for a walk and deconstruct and debrief things and look at how we might look at things differently. At the end of each year, we do have for ourselves a reflection and spirituality session that Russell Armstrong and I run together, and that gives us an opportunity to come together as a team and actually congratulate ourselves, which I think is a really important thing to do. On the whole, I think we look after each other just in our empathetic ways that we go about things. But we're also really aware that a lot of the work we do, we talk about how we wear a Teflon coat, because we have to protect ourselves from sadness and grief. We can't wear it, we can't take it home with us every night because we wouldn't be able to do the job we do. So in most cases, we can be present and we can do what we need to do, but we have to let the emotion sometimes slide off us. We're also aware that on some days we're like a sieve. Everything goes in. And they're the days that someone will walk back into the office after being on a home visit, walk straight into my office and close their door. I share an office with the other clinical nurse consultant, and that's the time that we drop what we're doing and we turn around and say, how are you? And we work through things case by case. Yeah, we could get better, but we're getting there.
And what are some of the trials you do?
Clinical trials?
Yes.
Yeah. So currently, we've got some trials on medications for breathlessness. We did a recent delirium study trial, and we've got, I don't know if I'm allowed to say it, but there is a new clinical trial coming up that I think we've secured that is around a medication for cachexia. And I don't know if you know, but cachexia is a syndrome that people get in the late stages of any disease, but ours is specifically a cancer cachexia trial, where there's loss of muscle mass, fatigue, weakness, loss of appetite, anorexia. So trying to slow or reverse those late stage effects, which in turn is about quality of life. So there's some trials. Interestingly enough, they're all medical trials, drug trials. We're doing some work now. We've got a research group that we've put together, and we're doing some research work now on whether people are dying in their place of choice, and are we getting it right? Because we want to know from our own team, are we listening and are we getting it right? So far, it looks like we are, but we want to put it together into a publication, because actually better than that, we think we're getting it more right than other services, and we'd like to be able to prove that. So, there's a question about whether we do things differently for adolescents, and particularly around dignity therapy, because people haven't lived a long life. We do look after children and adolescents here in Geelong. We have one of the clinical nurse consultants is our paediatric specialist palliative care nurse. So from a nursing perspective, we have a clinical lead there. We will all share the care, but she'll be the clinical lead. From a supportive care perspective, the interesting thing about dignity therapy is that it's very different to a life story. So a life story is all about, it can be chronological or it can be a story about, your whole life. Dignity therapy has specific questions, and there's 12 or 14 of them, but they're questions like, if you were flicking through your photo album, which picture would you stop at because it's made you smile, and tell me about that time. So it's trying to pick out those things that are important, those things that have formed who that person is, no matter how old they are. But legacy work for children can be very different. So sometimes it can be in art, so they'll do art and play, storytelling from a child's perspective, and we've got actually some really great resources. There's a lot of children's books out there around death and bereavement and grief. And in fact, we had for Dying to Know Day, Palliative Care Week, we had a children's story session at the Geelong Library that was really well attended, where all the stories had a theme of grief, but it was puppet shows and all sorts of things. It was really lovely. We don't get many paediatric, and I think the reason is that the Children's Hospital do such a great outreach as well. Yeah, we work really closely. Absolutely. Yeah. So, for example, we've had a teenager on the program who'd spent a lot of time at the Children's, but really wanted to die at home. But we would meet with their team at the house. We would continue the care. We were on the phone, email constantly. So we worked together really well. Yeah. No, good. We need to work together with all areas of healthcare. So we develop really strong relationships with the Children's Hospital, with the Andrew Love Cancer Centre, with the private hospitals. I think it's really important that we're all working together. Yeah, so that question's about once someone's passed away, about linking into bereavement services. So in lots of cases, the family and patient may already know the grief and bereavement counsellor as part of our team, because grief starts, of course, at diagnosis of a terminal disease. So they may have actually already developed those links. And if we get a suspicion or an inkling that there's going to be some complicated grief, maybe there's multiple deaths in the family, maybe there's complicated family structures that are going to impact on grief post-death, we would try and start that relationship nice and early. So we're not bringing in a stranger at a distressing time. But as part of our bereavement procedure, we actually keep in contact with bereaved families for 12 months. And that's standard, that's everybody. Now we do that in a number of ways. We do that by letter and anniversary cards. We do that by phone calls. And if in cases where people want that, we'll do that in a face-to-face situation. And we also have 2 remembrance and reflection ceremonies each year. And they're in May and November. In fact, it's on tomorrow at Linden Grove in Grovedale. If anybody wanted to come along, you would be more than welcome, where we reflect and we light a candle for those people that have passed in that time. And it gives us an opportunity then for those families to come forward and join in that, and also we're all there to give us a tap on the shoulder and say, I'm not doing okay, or actually I'm doing okay. So it's a nice way of reconnecting if it's their choice. Yeah, it's really interesting. So that's a question around voluntary assisted dying, which of course that bill has passed, but the actual act itself doesn't come in until July next year, and there's a lot of work going on now around what that's going to look like. And it would be a really normal assumption that would sit with palliative care. It's unlikely to. Given that our role is, I guess it will in some ways, but the actual assisted dying part would not necessarily be a palliative decision. It's going to be a really interesting landscape, and I'm not sure yet what it's going to look like. Barwon Health actually haven't put out a statement yet, so we're sitting in a little...
Did you see the survey? There was a survey went out to staff.
I did it.
Nice.
Good.
So that was interesting, because they're canvassing all staff.
About what we would and would not accept into our role.
It's going to be
Yeah, and I think it's really good because I think it's going to be hard for Barwon Health to have a statement around this without knowing how their staff feel. So I think that survey was quite in depth. You know, if you used the free text boxes, you could really say what you thought. So it'd be interesting to see how that comes together. You know, unlike some of the Catholic hospitals, you know, who have got a very clear stance on voluntary assisted dying. So yeah, so interesting times. Yeah, so the questions around whether change of government will impact on the Act actually coming into place, I don't know. I can't comment. And unfortunately, I was due to go to a forum a couple of weeks ago where one of the members of the Voluntary Assisted Dying Board was speaking, but Jetstar cancelled my flight home from Bali and I didn't get to go. And I haven't managed to get hold of the minutes or anything yet. So yeah, I'm not sure. It's one of those things that's going to be used as a political bargaining chip by politics, unfortunately. Yeah. Less about people, more about votes and things. Yeah. So around sort of what constitutes the network that gets support, there's no limit to that. Of course, there's a limit to our resources, you know, how many supportive care team people we can have out and about in one time. But if we do a bit of a family tree, well, it's actually not a family tree so much, but a bit of a picture of who's important, and it doesn't have to be family, and all of those people that are important become part of the people that we would look after. Yeah, so, and a lot of times, especially with young people, friends are such an important part of that care team, and we need to support everyone who's involved in that. And sometimes, particularly in cases like motor neuron disease, a whole community can require support. So, you know, in my MND role, I would quite often go out to small communities and just do a general information thing about MND because they were wondering what was happening and didn't know who to ask. So once we sort of alleviated some fears and stuff around that, then they were able then to provide more support to the family with MND. It was that bit of, I don't know what to do, so I won't do anything. But if you give people that power, they want to do things. Yeah, we can certainly get those out. So that's around the Advanced Care Directive link. So if you work for Barwon Health, it's all on one point and easy to find on there. If you don't, then it's the, I'm going to have a blank now. Anyway, if you want to know, I can find it.
Yeah. You would actually find it, and there's a lot of stuff.
Yeah.
It's not even just Barwon Health.
That's right. And there's also the My Values. So you can Google.
That's what I was thinking of.
Yeah, so that's Charlie Cork. Yeah. My Values, which is just a little questionnaire online. It asks you a lot of questions and you sort of say, yes, this is important, it doesn't really matter, or it's not important at all to me. And what it does is forms a picture of your values. So if you were to arrive at Geelong Hospital in a state where you couldn't speak for yourself and the person with you didn't know what you wanted, they can look at My Values and say, hey, this is what's important to them. So that would then guide what they would do. Use it as a guide. It's not a legally binding thing, but it's a good way of saying who you are. Yeah. It's a fairly new role, the role that I've made up for myself. And my manager has indulged me in, is being able to come out and do these things. And we go to community groups with Rotary and Probus and Lions clubs and all those sorts of things and just have a chat about it, because they're the people that are doing all the great work in our community and, and are certainly a starting point.